Hi, everyone. Welcome to the CoMaCH webinar. We're excited to have a good lineup of speakers today. I'm actually just really excited about the topic and the chance to hear from all of the speakers about how they've been responding to COVID and what it's like on the ground right now. So welcome to the CoMaCH webinar series. The CoMaCH network is a group of researchers and practitioners from South Africa, the UK, and beyond, seeking to radically include parents and caregivers in the design of relevant and sustainable digital maternal and child health interventions, as well as the research intended to drive this innovation. Through this webinar series, we hope to prompt discussion about approaches to research and practice to digital maternal and child health, to create a space where we can learn from one another and to work towards better outcomes in the first 1,000 days. And today's webinar is about really the work of the Perinatal Mental Health Project and other organizations, as well as the Messages for Mothers campaign led by Embrace and Side by Side and others to really develop a suite of messages to help parents really respond to COVID. And I think there's a lot of interesting stories I hope will come out of this. Liesl and Rita are both with the Perinatal Mental Health Project, and Rumbi is from Embrace. I see Liesl's been with Perinatal Mental Health Project since 2011 and has been working with the Hanover Park research team, and so has been working as a counselor and providing support to people with to mothers providing support to mothers in Hanover Park, and I'm sure beyond that as well. Rita's worked in the field of strategic communication, public and donor relations, advocacy and social mobilization in Asia and the Middle East, and as well as in Thailand. And she has been with the Perinatal Mental Health Project team since 2014. Rumbi, I see, in addition to being operation managers for Embrace, is an active writer and activist. She has a really cool blog, which is called Rumbi Writes, and her writing has appeared in the Oprah magazine, Vella magazine, feministsa.com, and myfirsttimesa.com. And so I will turn this webinar over to them. Rita's going to open us up. And then we'll hear from Liesl and Rumbi. After that, there'll be plenty of time for questions. If you have a question, feel free to pop it into the Q&A or just raise your hand, or whatever works, type it into the chat, and we will we'll look forward to hearing audience participation as well. Great. So let me stop the share.
Can I go ahead? Yeah, okay. Thanks for that introduction, Melissa. Good afternoon, everyone. As Melissa mentioned, I'm Liesl. I've been with the Perinatal Mental Health Project for 10 years. I'm currently the clinical services coordinator, and so my role is really to manage our maternal support service or counseling service, if you prefer. Let me just share my screen with you so that I can show you the slide presentation which has been prepared. Okay. So I thought it might be useful just to have a quick look at the prevalence of perinatal depression in low and middle income countries versus your high income countries. And so we can see that there is a higher prevalence in low and middle income countries compared to the general population. So as I mentioned earlier, I coordinate a mental health service in Hanover Park, which is in in Cape Town. Our service is based at a maternity unit run by midwives. And I just want to sort of be able to help you contextualize Hanover Park and what this community might look like. Also over here, we have some data from a study conducted by the PMHP. I think this could have been about 10 years ago. And I also just want you to have a look at the picture on the slide. And I mean, if you were to walk around in Hanover Park, this is what a typical structure, or this is typically what accommodation or living in Hanover Park looks like. And so you often find that in these one-bedroom apartments or flats, as we often refer to them as, you often find multiple families living in these one-bedroom apartments. And so it's very common for there to be overcrowding. Also, when thinking about Hanover Park, I'd like you to imagine a community where there is high prevalence of unemployment, a high prevalence of food insecurity, of poverty. And in addition to this, the community, you know, there's also systemic violence. And so the community is violent. And then we also have intimate partner violence. And in addition to that, we also have domestic violence. And so people living in Hanover Park are living in constant trauma. So gang violence is rife in this community. And when the gang violence flares up, you can sort of just imagine a community where people are having to be prisoners in their own homes. Just for you to get an idea as to what our service looked like before COVID-19. And so we were routinely screening clients coming for their first appointments. And so we work very closely with the staff at the MOU. And we would have, or we have a staff member who was screening the patients. And so we use a screening tool, you know, specifically looking at mood, and so depression and anxiety and suicidality. And this specific screening tool has been a big win for the PMHP, in that we've had the screening tool integrated into the standard maternity care stationery, which is now used across the country. But historically, we've been using the screening tool for all the years. So with the screening, so patients would be screened. If they qualified for counseling, they would then be offered the maternal support service or the counseling service, and that is when clients would then be referred to myself. Towards COVID-19, we looked at adjusting our service to a more stepped care model. And with the stepped care model, this allowed us to further triage our patients. And so those clients needing high intensity care, those clients were referred to myself, and then the clients needing low intensity care were referred to our junior counselor, Thanya. Okay, and then there was COVID-19. Obviously nobody expected this, and we were really forced to rethink and reconsider our maternal support service and how we were going to continue supporting our clients who seemed even more vulnerable during this pandemic. And so we decided to, sorry, I took that away now. We decided to integrate what we refer to as EAT sessions. And so Thanya, our junior counselor, was unable to be on site during the pandemic. And so she was working remotely. And Thanya was offering these EAT clients, these EAT sessions, with our clients. And so what was happening was Chambain, the staff member from the MOU, she was screening clients. Those clients who then qualified for the EAT sessions was seen by Thanya, and this was happening using Skype. And so a laptop was set up in a separate office where it would just be Thanya and then working remotely from home, and then the clients would be sitting in the office and they would be engaging with Thanya online. Tanya would then, do a more in-depth screening with those clients. And then once again, those clients would triage, and, your very high-risk clients would refer to me, and the low-risk clients, Tanya would then see them for counseling, and this would be happening online. In addition to the EAT sessions that were happening online, clients will also offer different support modalities. So WhatsApp Messenger, that was really came to the party for the PMHP, being able to support clients during the pandemic. And then we also offer telephonic counseling and then online counseling using Skype as well. I just want to mention that with the online counseling using Skype, this was happening at the facility, so at the MOU. So where some clients didn't have access to a smartphone, or where it wasn't going to be advisable for them to have telephonic counseling, we had then arranged for those clients to have Skype sessions when coming for either the antenatal appointments or the postnatal appointments at the facility, so at the maternity unit. And once again, this was set up, the laptop was set up, it was secure in another office where clients were then able to engage with Tanya online. We experienced quite a lot of challenges, specifically around privacy and confidentiality, and just thinking about the security of the devices that we were using. We needed to give expansive consideration, thinking about which digital platforms we were going to use, which would be safest for our clients. And so there was extensive research that between Tanya and I, we were having to do, thinking about privacy and confidentiality. I think it's important to note that, as mentioned earlier, that a lot of our clients are sharing homes with multiple people. And so there isn't a room to go into, there isn't a garden where they can go sit in, and have a phone call or a telephonic session. A lot of our clients also don't have access to smartphones, or they're sharing their phones with other family members. And these were conversations that we were needing to have with our clients. What is going to be safer for you? What happens if we've been having a WhatsApp chat and somebody else has access to that phone? How are we going to ensure your safety, especially in the case with domestic violence? These were really important conversations we were needing to have with our clients. And then also thinking about the security of the devices we were using, whether it was our cell phones or our laptops, and making sure that all devices were password protected, and constantly reassuring our clients about confidentiality and the security of the devices that we were using. And then the benefits of going online, using digital platforms supporting clients was, I think, more so for Tanya, who wasn't able to be on site. That she was able to support clients from the comfort of her own home. And there was convenience with that, that she didn't need to come to the MOU, that she didn't need to be at the facility in order to be available to her clients. So I think for us, that was great, in terms of the convenience of using digital platforms to support clients. Also, being able to provide valuable therapeutic interventions to our clients using, the Skype, as mentioned earlier, or telephonic counseling. And then also mentioned to you earlier, WhatsApp really came to the party for the PMHP. We were able to have in-depth counseling sessions using WhatsApp, but then also very brief check-ins and informational sessions, whether it was around COVID-19 or birth preparation or breastfeeding. And so we were really able to, just in terms of monitoring and evaluation with using WhatsApp Messenger, we were able to categorize, our counseling sessions, whether it was brief interventions or more in-depth interventions. What we learned from going or using digital platforms or going online was the value in the service, that people, we had imagined that there would have been a reluctance for our clients to go online, and yet it wasn't like that. There was a great response and a buy-in to the service and our clients connecting with that, whether it was face-to-face or whether it was still going on, or supporting clients online. And so I think it was just, we were able to learn that, just people needed support during this time. And even though patients preferred having their face-to-face sessions, people were still opting, to have the brief check-ins on WhatsApp, or were still wanting to do birth preparation, for example, online. So I've just been able to realize the power of using digital platforms, being able to support our clients online. I don't know if I still have time left, or I know I rushed through that now. I was very mindful of the time.
I totally forgot that I was supposed to be keeping time. Was there anything else you wanted to share? I
think for me personally, like I mentioned, I think when Thanya and I were sort of thinking about going online, I think we both experienced quite a bit of anxiety around what is this going to be like? We're not used to engaging with patients using Skype, or we're not used to engaging with clients using Skype, using WhatsApp. We're used to sitting in an office, a clinical setting where we have the client opposite us, and I think with WhatsApp sessions or with online sessions, you're really using the same skills. If a client messages you and says, I'm experiencing distress, or, this has happened and this situation has happened, you would contain your client the same way you would have if she was sitting in your office. And so it was really just transferring the skills that would be used in a face-to-face setting and using those skills online.
Yeah.
And so, yeah. So for me.
So in previous webinars, we've actually done Q&A after both the talks, but I think for this one, we were just planning to do Q&A after each talk. Okay. So if you have a question, go ahead and raise your hand or put it in the Q&A. I'm going to ask Leanne to maybe make a few of you guys co-panelists, so you can just turn on your video and start asking questions. And then you'll find, Liesl, you'll find actually the Q&A. I think you can access it. You can see a couple questions there already, one from Hafeni. Leanne, can you make Hafeni a panelist, and maybe she can ask a couple of questions, but I'll read the one that's here. Are there particular maternity obstetric units that you work with? And did you have to supply the phones or laptops to these MOUs, or would you make use of resources already existing in the MOU?
Okay, so we currently only have a clinical service at Hanover Park Midwife Obstetrics Unit. And with, we sort of gave our clients different options. And so if they had a smartphone, they were able to then opt for WhatsApp counseling sessions, or if they didn't have a smartphone, would having a telephonic session work for you. And so it was really just about thinking with the client about what would work best for them. They were also given the option of waiting for their next antenatal or postnatal visit to see myself for face-to-face counseling, or having a session with Thanya using Skype. And so with that, we would provide the laptop. The client didn't need to, they would come over to the office and everything would be set up. It was just a matter of letting them into the room. Thanya would already be online waiting for them. And then also we did make it available to our clients that if they needed data, that we would then provide that for them. Does that answer the question? Yeah.
So let's see. Hafeni also asked, are there any major challenges that stood out for moving online?
Initially, there was a lot of troubleshooting. There was a lot of trial and error. I was speaking to the director of the PMHP last week, and I was sort of recalling what it was like with Charmaine was doing the screening, Tanya was working online, I was here. And so there were times where we were all sort of like running around like headless chickens, you know, and it was like, oh, flip, like we need to go get that client, Tanya's waiting. Tanya would then be like, Lisa, are you available to see this client? And so it's, for me, it took quite a while to get like into a system and for the three of us to get into a flow that really worked well for all of us. There were a few technical glitches. I think there was also load shedding last year. And so having to think with clients, okay, like if there's load shedding and this call ends now or the call cuts out, you know, is there a phone number? Can I call you? And so it was, you know, like I mentioned earlier, there were a lot of things that we needed to think about with going online. Making sure that your phone is charged, that the laptop is charged, that you have a bank charger. Yeah, but I think also important that the three of us learn to communicate with each other. So for Charmaine to let Tanya know, I'm going to start screening. For Tanya to say, Lisa, if this client's for you, are you available to see her? Must I send it to you? Must I send her back into the clinic? You know, how is this working? So, yeah.
Can you remind me, was the screening done in person or was it done remotely also?
So the first part of the screening was happening on site, and the staff from the maternity unit, she was doing that initial screening. Then from the clients would then be seen by Tanya, and that was happening online.
Okay, I see.
How they would answer the mood questions. So if they had answered yes to suicide, not suicidality, if they answered yes to depression and anxiety, they would then be offered an EAT session with Tanya. Also, if they, you know, if there were symptoms of suicidal ideation or suicidal behavior, they wouldn't go through Tanya. Those patients or clients would then come directly to me. And that would also be happening on site, face to face.
Yeah.
Yeah.
I have to check on something in my house, but I was wondering, actually there are, I don't know if you can access the Q&A.
I'm seeing the questions here.
Okay.
So, okay, Pfizer Tofi mentioned that WhatsApp also really came to the party for them. Dominique Oosthuizen, how did the patients find using these tools like Skype for the first time? So, I mean, you know, as I mentioned, we initially thought that patients would, or that our clients would be quite reluctant using digital platforms, engaging with Tanya. But especially with Skype, everything was set up before the time. They didn't have to do anything. So they would see Charmaine, they would then ask, would it be okay if you spoke to one of our other counselors? You know, and we explained that this would be happening in a separate office, that there's a laptop set up for them. And so as soon as they went into the office, Tanya would already be online. And so we didn't really require for patients to connect or disconnect or to call or to end the call. So we try to, you know, with using Skype, we really try to make it as easy as possible for our clients. So that, you know, because we know some people do feel a little bit intimidated by technology and by platforms such as Skype or Teams. And then Dominique also asked, are you going to continue these online services post COVID? So, I mean, services in terms of, you know, how the maternity unit runs, that is pretty much returned to normal, but we are continuing to offer WhatsApp sessions with our clients, telephonic sessions with our clients. So, you know, once again, if that is what works for our clients, and that is what we will continue to offer them. How did you manage language barriers, especially when it was a phone call? I think we sort of the same way we would if we were sitting with a client face to face. I mean, first of all, if it's not possible really to engage with a client because of a language barrier, then we wouldn't be offering them the counseling service in the first place. So then we would sort of look at other referral pathways and look at organizations that might be able to offer them counseling in their language. So I don't think, if there was a language barrier that would make it very difficult to, to do sort of in-depth counseling with the client, we wouldn't offer them the counseling service. Then we would consider other organizations that might be able to do that for the client. Did remote counseling affect the way clients expressed their challenges? How did you react to the emotions, body language as they talk to the counselors? I sometimes found that clients were actually, especially with WhatsApp, clients were really good at being able to express themselves. And like I mentioned earlier, the same skills or the same interventions that you would do with a client in a face-to-face session, I found that I was using those same skills, with clients online. So reflecting, so you sound really angry, or this sounds really hard for you. Yeah. With body language, it was a little difficult. It's easier when you sort of have a client with you in the office. But I found that clients, especially with WhatsApp Messenger, that it was sort of helpful for them to be able to type it in a message or to send a voice note.
Great. Thank you so much for your answers. I think we're going to invite the next two speakers. Thank you for sharing with us. I think if there's also more time at the end, people can also ask questions, and we'll make some time for any questions to be answered. So thank you very much. And Rita and Rumbi, go ahead.
Thanks so much, Melissa. Just sharing my screen so you guys can see the presentation. There we go. Okay, so thanks so much. My name is Rumbi Görgens, and I'm here with my colleague Rita Stockhow. Wave, Rita. I work for an organization called Embrace. We are a movement for mothers, and we're dedicated to finding ways to bring motherhood, the motherhood agenda, to the table where decisions that affect mothers are made. So we don't work directly with mothers, but we work at a kind of a systemic level to ensure that we are kind of pushing the levers that we need to push for systemic change for mothers. And one of our partners is the Perinatal Mental Health Project, for obvious reasons, because they're concerned with the mental health of mothers in the perinatal phase. Embrace is also, is especially concerned with making sure that every mother has the best start possible to their motherhood journey. So whilst we don't work directly with mothers, a lot of the issues that we are grappling with in our work relates to early motherhood, and specifically mothers who are in the trenches of those first 1,000 days, where we find that there's a lot of intention and focus on the children in the first 1,000 days, and that kind of sometimes negates or goes over the needs and the concerns of mothers. So Messages for Mothers was a response to what we understood were going to be very clear kind of communication gaps with respect to surviving the pandemic and protecting families and children against the rising infection rates. So it was a labor of love, and it was also the result of a coalition formed by, I don't know if you can see the range of logos that we've got at the bottom there: Perinatal Mental Health, Embrace, Grow Great, Ilifa Labantwana, and Side by Side. And it really began as a project by these organizations who we have in our audience, families with young children, mothers who are raising young children, and we understand that a lot of the public health messaging that is delivered to our audiences is not necessarily addressed in a way that is going to kind of land, and in a way that's going to be the most efficacious or the most helpful. So we know there's an existing information gap in public health messaging with regards to parents and with regards to mothers in particular. And with COVID-19, we knew that would be exacerbated, because this was, I mean, for the first time in in a lot of people's lifetimes. We had a global pandemic, an infection rate that was rising at a really alarming speed. And, you know, we had families who are now tasked with protecting themselves and their children against this infection whilst they were stuck at their homes altogether. So it was unprecedented situations in people's homes. And we knew that we were going to need specific information to feed into those gaps. We also know that motherhood, especially early motherhood, comes with social isolation. You know, for a lot of mothers, those first few weeks that bleed into the first few months are very isolating. You're healing from birth, and so you're not kind of going out, you're not seeing people that you used to do. Your life has changed fundamentally, you know, and so it can be a time of intense social isolation, where mothers kind of lose the kind of tenuous connections that they may have had to other parts of their identity and the support available there. And we knew that COVID was only going to make that worse, because now we really are physically isolated from one another. And we knew that COVID-19 was having a massive impact on people's mental health. We were all stuck at home with our very young children. We were all anxious. People we knew and people we loved were getting sick. Some kind of, you know, some mortally so. And so it was a time of heightened anxiety. And then, you know, we also knew that with the closure of schools and early childhood development centers, daycares, creches, parents were now going to be faced with, you know, if they were not working or if their jobs were not kind of classed as essential, they were now kind of in the unprecedented situation of being with their children 24/7 in a way that we never have been before, right? Even when kids go on school holidays, parents are often still working. And we are still kind of making childcare arrangements, and they are childcare arrangements available for our children. During COVID, at the very beginning, all of that stopped. Most, you know, children were home, and in some cases, parents were home. And in other cases, parents weren't, so they were essential workers, but they know that their children are at home without the usual sources of entertainment, of stimulation that they might have had at like a holiday program or a daycare center. So knowing all of that, Messages for Mothers came together, and we focused on these pillars of information. So the four core pillars were physical health resources. And we knew, because there was incredible uncertainty at the very beginning about what this virus meant for women in the perinatal phase. What did it mean if you were pregnant? What did it mean if you were about to give birth? And what did it mean if you had a newborn, right? We know that the perinatal phase in a woman's life is a time of heightened vulnerability. And so what does that mean in relation to COVID-19, and how does that limit what you can do as a pregnant or as a newly postpartum mother? And then mental health was another big major one, because people were we were all understandably kind of dealing with the uncertainty of, first of all, just living our lives in this new, different way, with very kind of limited connections to one another, but also the anxiety of this virus spreading at an alarming rate, and people we know and love falling ill and some passing away. And then parenting in the pandemic really came out of this idea of trying to give parents, first of all, just the reassurance that this is unprecedented, right? We've never, you know, our children have never been out of school completely for this extended period of time without any kind of alternatives to school programs. But at the same time, they've also never been, you know, they've never been facing the kind of information deluge about a virus that they're facing here. Children were being bombarded, same as us, with information about hand washing, about sanitizing, and so anxiety comes with that. Mindfulness was also related to the mental health, to kind of help moms find spaces, even when you don't have the physical space, because now suddenly your household is full, everyone is at home, and you might not have the physical space to power down and to take a minute for yourself. The kinds of messaging, the kinds of content that we put out, the format. So all of the content sits primarily on messagesformothers.co.za. That's one word, messagesformothers.co.za, which was kind of our holding space for all of the messages. We also have basically mini podcasts that we made, which is people who we've asked to record themselves reading some of the content in various languages, and that all sits on SoundCloud and on Headliner. And so you can still find that. It's on PMHP's SoundCloud account, because we are aware that, asking you to access a website and possibly read an article might be beyond what you can do right now. And we also had the messaging was quite dense, as you can imagine. And so to make the messaging travel, and to also make it easy for people to use and share it, which is what we really wanted, is for you to feel like this is information that you can pass along. We developed a visual, quite a very specific directed visual language that would speak to a variety of mothers. So you can see yourself. It's not so specific as to leave you out, but it's also not kind of just stick figures. It's relatable enough that you can see yourself in the representation, and the representation and the images and the colors don't distract you from reading the messaging. So it was also, we made it shareable via social media, so you can share on Instagram. You could also share on stories, which is why we have that kind of long format, which is works very well for social media. And this is kind of, I've taken a snapshot, I stress it's a snapshot of a month in the life of Messages for Mothers, just kind of showing that social media is really where it took root. So Instagram impressions and Facebook post impressions are where things really kind of picked up. So the reach is the number of people who the message would have gone out to, and impressions is the number of clicks. So what you're seeing is the reach was being multiplied in the number of clicks, which shows a level of engagement. So people are coming back, they're seeing it, they're clicking on it, they're coming back to it again, possibly sharing it, possibly downloading it. It was all designed to be very easy to download and save to your own devices. Then what I'm going to go into now is just a little bit of a review, and I'm drawing quite a bit on research that was done by the Research and Training for Health and Development group, RTHD, based in Johannesburg. They did a series of focus groups with Messages for Mothers users, and I'm drawing quite a lot on those focus groups to just take you through some of the lessons we learned. So in terms of our reach, targeted dissemination through coalition partners is what worked. We didn't set up a separate Messages for Mothers Facebook page or Instagram account or Twitter. We relied, because this was initially developed with our existing audience, with the coalition partners' existing audiences in mind, we used those existing channels that have credibility and already have dedicated followings to push the messages out, and that worked incredibly well. And partners like Ikamva Labantu and the CoCare Project, because of their association with us, could easily use the messaging because they trust the coalition partners. Social media was key. People just did not go to the website, which I can fully understand. The website holds everything. And so at this point, it's very massive and it's clunky. And social media was where people were really accessing the messaging. Images are so much better than text and audio. They're very easy for people to share. There's something about consuming something in an image that is, it's a lot more, you can consume it. It's quicker to take the message in. And then it's also very easily shareable. And newsletters. We had a newsletter that went out to a mailing list that was built for us by Side by Side. It goes out to about 2,500 people. And that in that newsletter, we would embed links that would allow people to download batches of messages. And that did remarkably well. And again, it's another example of us using relationships with partners to rely on them to get the message out. What didn't work, we had no dedicated Messages for Mothers social media presence. And so the brand recognition was a bit fuzzy. When you spoke to people, they kind of would, depending on how they found out about us, conflate Messages for Mothers with PMHP, with Grow Great, maybe with Embrace. Not really a downside for us, as long as the messages are getting out. And then we found that because we were kind of in the region of pushing out our messages to coalition partners, it's harder to measure what's getting out to people who might not necessarily be as familiar with the coalition partners. I'm just going to hand over to Rita. Sorry, I know I'm going on a bit long. Sorry, Rita. Just going to hand over to Rita, and then
no, it's fine. You already making some of the points that I'm going to make, but that's fantastic, because coming back to what you just said, we didn't have one dedicated platform. It actually worked out in our favor, because every partner had such different audiences. Like you said, your WhatsApp and your Facebook is your main platform. Our main platform is Twitter, LinkedIn, and now also Instagram, because our partners, our audiences is researchers and healthcare practitioners. So at the end, even though if we would have planned this campaign like properly with, this is our goals, this is our targets, we would have possibly done an own social media channel. So we didn't, because we were just following our gut feeling and we were running with it. But it worked out perfectly, because we were present on all social media platforms. We reached a much wider audience. And at the end of the day, as you said, does it matter if it's really people can remember it was Messages for Mother? No. So I think that's actually also a positive when you think about it. Then also coming back to what you said with the holding of the content, because of course in the beginning we thought this is going to be a project for a couple of months, and we were storing all this content on our different websites. So it started getting very confusing. Where's what? And the PMHP had all the mental health content, and then side by side. So we realized, actually, no, this is one thing we have to consolidate. So for me, and I think also for all of us, the one thing is consolidate your content into one place for people to know where to go if they want to download. But in terms of social media, no, run with your own accounts, because also you can never reach that many people with a new account that started from zero. And then one of the other interesting things was, because we didn't plan this, we didn't have a communication action plan. We were thinking of like what works for us, like we as the PMHP, for instance, we work a lot by tapping into existing campaigns, like worldwide campaigns, national campaigns. So we did that exactly with the Messages for Mothers. So we took the Messages for Mothers and actually embedded them into our World Maternal Mental Health Day campaign. And it worked very well. The National Women's Day, South African National Women's Day, worked perfectly. World Breastfeeding Week. So we looked at all those international, even though the messages were designed for South African mothers or parents, it actually worked very well to tap into existing campaigns and not to start our own. And then just the last one with the visuals, you mentioned that before, because there was so much to talk about and there were so many informations. So some of our messages in the beginning were quite dense, as you were showing it with the long, they don't work on Instagram. So we actually adapted them as we were going. And I think for me, when talking about what worked, what doesn't, I think what works the best is like run with it, learn from it, change things if they don't work, but don't stop and start planning first or plan not doing this first. I think what we did is we looked back at everything that we sent out and we looked at it and said, this doesn't work, we need to change it a bit. So that's my short lessons learned. Back to you, Rumbi.
Thanks, Rita. Yeah, absolutely. That was one of the key lessons, and it's bled over into all of, definitely with Embrace, we've learned that a crisis can really speed things up in an amazing way. I'm not going to talk through all of these because I have mentioned them, but the two key things in terms of the content were that it in terms of mental health issues, it gave us an opening to start talking about mental health issues that mothers face that are sometimes taboo, specifically with respect to perinatal distress. And we found that the mental health messaging in particular was extremely popular on the website and on social media. The plain language editing was key. So we had quite a complicated editorial process in that we would kind of run the content through a number of kind of iterations and vetting, but it would always go through a plain language editing to make sure that even though it's in English primarily, most of it is in English. A lot of it has been translated into 4 additional languages, but mostly it's in English. But even though it was in English, it was in accessible and pragmatic English. Yeah, and we found that in the RTHD review that some people spoke about that the translated material is sometimes quite dense. It's translated into kind of a formal version of the other languages instead of vernacular, and so it's easier to just access the English. What didn't work, and this actually started emerging towards the end of 2020, the beginning of this year, is we were inadvertently adding to the mental load. There's another thing for mothers to think about, in addition to everything else that mothers have to think about. And COVID-19 information fatigue is real. People, at the beginning of the year, people did not want to hear about COVID-19 anymore. And then a lot of the feedback that we got, the messages that we would get from the mothers were kind of about this very serious dire effects that COVID-19 has had on people's already shocking circumstances in which they're living. And the nature of the project, because it was informational, means that there wasn't, other than kind of creating referral networks, there's not much we could do to directly address the material deprivation exacerbated by COVID, which is, you know, it's not, you know, anything about the nature of the project, but I think that's one of the things about the work that we do. And I think PMHP will know that as well, is when you're focusing on a particular aspect of, you know, mental health is so tied with people's material situation, and it can be overwhelming sometimes to figure out how to address and how to support in the circumstances in which a lot of South Africans live. So associated behaviors and practices is what the review called it. We didn't set out to change behavior, obviously. This was an informational project, but there were some useful changes and useful behaviors and practices that emerged. M4M is an authoritative source, I feel, on COVID-19. And what emerged was organizations and programs that work directly with mothers. So the Flourish franchisees, who are, it's an arm of the Grow Great campaign, which is aimed at reducing stunting, that offers at-cost antenatal support groups and postnatal support groups for mothers. The Flourish hosts, who host these antenatal and postnatal groups, drew on messages for mothers in their sessions with mothers. And so that was an unexpected bonus, where people who have kind of contact interventions were starting to draw on this work. What didn't work, we checked the referrals that we made to organizations like SADAG. And while we can check the referral and make sure that the phone is being answered, there isn't really anything we can do to vet or ensure that the information or the help that you're getting from a referral source is what you need. Keeping up with the pace of change. Look, it was a good thing because we were changing, our content was constantly changing, and that was fine because the information around the pandemic was also constantly changing. I remember at the beginning, there was not really clarity around masks, only that we should try to not buy medical PPE, leave that for the frontline workers. But then then cloth masks became a thing. And so then we had to kind of go back and insert information on masks and everything. It's also, this is only accessible if you have consistent access to data and Wi-Fi, and printable materials might actually travel even further. I'm just going to leave you with feedback that we got through RTHD about a change that occurred in an indirect user because of the message, the family violence messaging in particular, that we put out at kind of at the very beginning of the pandemic. So this is a woman who had seen kind of some mention of domestic violence in messages for mothers, information that was shared by someone else. And it opened her own eyes to her situation and the abuse that she was going through. So I thought that's a nice note on which to end. I'm sorry, I know I've gone way over time. Sorry for this.
Last time for questions.
Yeah.
Great, thank you so much for sharing this. I think there's a lot of really interesting insights, and one of the like immediate questions in my head is like, you know, how much of what you've learned is like written it down in a way that the next group trying to put together messages for mothers or messages for anyone can learn from your experience. And to that end, I'm wondering, like, was this all done mostly by instinct, or like was there a sort of existing knowledge or whatever that helped you to, like, you know, conclude to format it like for Instagram posts and for like Facebook stories and you know, making it short and focusing on images. Like I think that, like, you know, what are the next, I think there's does research help practice make this kind of stuff better? Whether it does or not, like what could be our next steps so that like next group doing this is going to feel informed? Yeah.
So I mean, Simone Honigman of PMHP is on this webinar as well. So Simone, if you want to jump in, but you know, it was instinctive in that the questions that we knew people were asking and what we were looking for answers to, but we relied heavily on the expertise of medical professionals and people engaged in research and practical work with mothers and with young children. So this information was heavily vetted, and especially when it came to the mental health information and the physical health information, because we know there was a lot of misinformation out there about COVID-19. So I guess, you know, what we learned from this was to find a way to kind of tap into those existing knowledge banks. And that's what Simone and PMHP did very well for the project. Simone, I don't know if you want to jump in. I don't want to put you on the spot, but.
Yeah, thanks. I mean, I think it's a very important question because but I think the question is about research and how others can learn from our process. We were very lucky to have a person do a range of interviews with various stakeholders and write a report for DG Murray Trust. So that report is available. And we were also very fortunate to have this external research agency do these in-depth interviews with different types of user groups of the messaging. But we did flirt with the idea of should we be more rigorously evaluating and researching what we're doing? Should we be navel gazing in a more robust kind of way? And there were certain volunteers who were going to go on and write a paper on on looking at what we were doing through a feminist analysis. We were looking for students. There were different ways but there was so much work to do that in fact the kind of we couldn't slow down. I mean, there was such a pace that we actually couldn't slow down. We didn't feel that we could afford to slow down and construct a research protocol, a research process, anything beyond that. And we felt that the focus about producing the work would need to take precedence, and that the reporting that we were lucky to have available to us from those two sources was a good enough process. We did have regular meetings which were very reflective and very sort of analytic. I think the kind of the knowledge, you asked Melissa about the knowledge base. I mean, aside from the technical knowledge networking around technicalities around the messaging, the coming together of a coalition of partners brought extraordinary wealth of knowledge of how to work with different audiences, different social media platforms, different campaigns. And I think, Rumbi and Rita are the stars of the show there in that respect, because they have brought together, it was like a mushmash. It was literally coming together of people bringing different angles of this complex puzzle. And the tone of the engagement and the mutual respect and the kindness between the coalition partners meant that we could really tap into those skills and use them in a very mutually complementing way. And the kind of due process and procedures and terms of reference and letters of agreement and all of that, we just had no time for. There was no luxury to do that. But without all of that, it just clicked. So yeah, I'm not too sure if that answers your question in a rather roundabout way. That report is available. That report is available. Both of the reports that I mentioned, and we can send the links.
Yeah, please send the links to the network, and I think it's something that should be incorporated into like even the literature review that we're working on. Just because, like, even if it's not like a peer-reviewed journal, like there's knowledge there that I think others should be able to draw upon. And I think when I'm thinking knowledge base, I know there's like lots of knowledge about parenting and all of this stuff, but like how, like that knowledge base around the skills of using social media and to go through influencers and to like basically empower community-based organizations to take up the messages and share it, I think is really, really important. And it's not something you see in a lot of these campaigns. Maybe we're seeing it more and more, but more often you see posters on the wall, which nobody looks at, and you see SMS message campaigns, which, it's really hard to have an engaging conversation around it where people can go into depth. And so, I mean, I think there are a lot of aspects I like about like how messages from other brought together content from a lot of different sources, worked hard on that. I think that language thing is a really interesting thing because it's something we found in our own research too, where people actually want the English content over the very technical, and that like even this process of translation is so complicated because you can translate into somebody's home language but not translate into their home dialect. And that choice of formal versus like informal can really influence how they respond to that messaging. And I think this for me puts forward a lot of open questions that if we can actually use research to answer and affirm your findings, then that's something that could really make a difference in how we do messaging in the future. I'm trying to see if there's additional questions. Faiza says, thanks for a great webinar. And she's excited to see how COVID's pushed us beyond what we thought was possible. Kira Lee from Digital Medic asks, I'm interested to know your plans and or thoughts for this platform. Will it be used for other key messaging? Will it integrate with Mom Connect or other platforms?
We would love to integrate with Mom Connect, Kira. We've been trying, we tried, and it was a long process, and anything that goes out on a government platform has to go through certain checks and balances, and we just never quite kind of got to the next level. But I can say with confidence that a lot of the content that Messages for Mothers put together was used in other government platforms And some of it actually is on the Department of Health's WhatsApp bot, you know, that WhatsApp bot that they developed once the pandemic hit. That messaging is on there. You won't find it branded as messages for mothers because we just wanted to get it out. It doesn't really matter. The branding wasn't important to us. In terms of where Messages for Mothers is going now, so I mean, it was, like I said, in a lot of ways, it was a labor of love. We were all kind of taking time away from other things to do this. It wasn't kind of funded separately. And so, you know, we've all kind of had to go back to our core work. It still sits there and the information is still being updated. But we haven't, I think the intensity has reduced somewhat. And I still think that there's room for kind of printing some of the content and really getting it out there, because I think the printed content will travel a lot further. But as I say, again, it's a labor of love. We were all kind of borrowing time from other things to do this. So, yeah.
We were also able to integrate the messages as the first appendix to this National Department of Health COVID policy framework response for the pandemic. So there was a maternal and child health policy framework response to a crisis/COVID pandemic, and that got sort of sign-off, very senior sign-off at national, but included everything to do with maternal and perinatal health, physical health. And they were very happy to have us kind of write a big chapter of that policy framework on messaging. And then the appendix it is a live document, so it was updated with, and is still being updated with all our messages, which is great, and is on the Knowledge Hub, the National Department of Health Knowledge Hub. I think newer iterations still haven't gone through a sign-off, so a bit of an old iteration is on the Knowledge Hub platform. The question around Mom Connect, I think Mom Connect has now been reduced predominantly to an SMS platform. We worked really, really hard to get it onto Mom Connect, but you know, funding did not allow for, you know, it's expensive, and funding did not allow for that, unfortunately. But I think going forward in future, there's scope for these messages to be disseminated through Mom Connect. We hope, yeah.
I think I have one last question for everybody, and my question for kind of all the panelists is what are the big questions that you guys have that you didn't have time to answer maybe, or that like through the work you did, like you would like to see researchers, computer scientists working on, not necessarily computer scientists, but researchers, potentially researchers with technical chops. What would you like to see us working on that you think would actually help, like, you go through all of this again?
I'm going to go first. And I don't know if this is something that is within kind of what researchers can do, but I would absolutely love to find a way to make platforms like this one, and also, you know, platforms like the ones Liesel's talking about, when you're using WhatsApp and when you're using Skype and Zoom and all of those for service provision, for non-profit purposes. I would love to see how we can make them accessible without the prohibitive data costs. Like how do you, because it can be such an insurmountable barrier. I mean, even still now in some of the work Embrace does as well, you know, we go through cycles of doing work and we have to send data before and it just keeps going and keeps rolling. And there has got to be a way. We know that there are ways to get certain platforms 0 rated. There's got to be a way, a more painless way to make these platforms accessible at no cost to really the most vulnerable people.
that's a great problem. I think everybody agrees.
Totally agree. And I also, tapping onto that is, if we could have, if there would be a research project that I would do ever in my life, it would be like, how much is actually from your reach and your impression actually arriving at the people? Because we're always talking about behavior change and I come from the communication for development part, but this whole digital world and the social media campaigning, we don't know what it actually does with people. We know they flip through, they saw the picture, they maybe clicked on it, but what does it do? And that for me is such a fundamental question also, which we can't answer now. How many people actually read it or just Masoma said, ooh, looks pretty, poof. I know that's a hard question to ask, but that would be my research question.
Yeah, I think
do you have another one?
Yeah, and how can one further tweak? How can one further tweak the messaging, the imaging, the language, the amount of language, the volume, the pace of delivery, how can one tweak that to maximize the impact of the messaging? A kind of market, like a real market research kind of thing.
Yeah.
In people who are being bombarded, in a scenario where people are being bombarded and they're being lectured by the nurse like this, and they're getting something like that from the SABC News, and they're getting something else on the radio, and they're hearing something else in church. How do people navigate all of that knowledge when they're seeing a Facebook story or a WhatsApp or an infographic? How do all of those bits of messaging work together for them? How do they sieve and integrate that messaging, and how does it change what they do?
Yeah, my intuition on that is that it isn't about how frequently you're sending or the format or like the wording or whatever, but it's about the partner communities like Flourish coming in and picking and choosing from the messages and tailoring it to the needs of the local, like to the moms that they're working directly with. But I think that is definitely another great area of research. My PhD student Sarah, I think, is really thinking hard about that question. Liesl, did you have any big wishes for us as we wrap up?
I think I'm definitely with, I agree with Rumbi around thinking about how can we make e-counseling or, how can we make these digital platforms available to these very vulnerable groups of people who unfortunately don't have access to Wi-Fi or don't have access to data. So I think, I think it could be very helpful if there was some sort of thinking around that.
I'll tell you my answer. We have fallen into this trap of believing that all communications, all network communications means connecting to the internet. When really network communications is supposed to be connecting people to people, devices to devices. And if we leave off the internet, right? Like, and when we build up local communication networks, local communication infrastructure, build up ways phones can talk directly to the phone next to it, rather than having to go through the towers and pay MTN for every minute, then I think communities will be more empowered to actually share and develop better connections even within the communities to support the families that are there. So that is my research agenda and where I hope we can go. I think that's something that we're thinking a lot about, and hopefully we'll have a chance to partner with you guys on making this happen and seeing what will work actually for the parents on the ground. Nerva would like to announce the next seminar before we wrap up.
Well, we are still waiting information from one of the panelists, but in May, there is going to be a webinar on the use of visual methods and creative methods for understanding the experiences of motherhood. So we will have Naveen from India talking about the use of different methods in pregnancy care. We will have also Daumanai from Cardi, the use of different creative methods here in the UK. And we will have another speaker from Sweden also talking about the emotional pregnancy and how different methods were used to get all the sensory experiences. Yeah. The link is here, but I'm still waiting for one particular information, but you can still register now. Yep.
Yeah. Thank you so much to all of our panelists and to Simone for helping to coordinate all the speakers for this webinar. We're really excited to just have had this chance to connect with all of you and hope to talk to you again. So thank you so much for your time. Thank you so much to all the attendees for your questions and your attention, and see you again next month.
Exactly. Yeah. Bye. Thank you.
Bye.